anticoagulant and then back on.
So this is somebody who is several months out from an unprovoked VTE, so high risk for a post-op thrombosis also. And how are you going to transition him from, was it dabigatran or any DOAC? Which
So
was the DOAC?
we can talk about both the direct and the 10As.
Yeah, so all of these drugs, DOACs slash, any of the DOACs, direct thrombin inhibitor like dabigatran or 10A inhibitors, you have to be a little bit careful perioperatively, purely because of the potential reversal related issues. And depending on your renal function, there's different stopping times. They range anywhere from 48 to 72 hours from the last dose. Okay, so you can basically stop the drug and wait. In patients who are extremely high risk for thrombosis, like somebody with antiphospholipid syndrome, who of course is not going to be a DOAC anyways, but sometimes you have to bridge those patients with low molecular weight heparin. Okay, so this gets a little bit more complicated. So imagine you're on a DOAC, you need a procedure, and you can't be on anything for 48 to 72 hours. In most cases, you don't need to bridge them before, but in some cases where patients are extremely high risk, you may have to switch them to a low molecular weight heparin just because it's safer from a perioperative standpoint to get them to surgery. And postoperatively, there are starting rules depending on the comfort level of the surgeon and the bleeding risk post-op. So neurosurgery, you have the least level of comfort resuming anticoagulation immediately. You wait 72 to 96 hours, but if it's an EGD, you can start them on anticoagulation that same evening. So it's a little bit more complicated question to answer, but those are the general rules that we follow.
Patients who have end-stage renal disease on dialysis have a much higher bleeding risk. Is there any safe anticoagulant to use in those patients when they develop their VTE?
So a great question. What do you do in ESRD patients? I'll tell you a very practical approach to this. So for ESRD, AFib treatment, apixaban is approved. Okay, apixaban is not approved for VTE treatment in ESRD. Okay, and there are two different scenarios. You can use it for AFib, but not really for VTE. What we generally do is initially we use unfractionated heparin slash warfarin for a few months. And when that kind of thrombosis risk becomes lower, you could consider renally dosed apixaban 2.5 BID. Again, this is somewhat of a controversial topic, so you have to take everything I say under advice. It also depends on how compliant the patient is. The best answer, the board answer, is warfarin. Okay, so the board answer is warfarin for patients who have end-stage renal disease and require VTE treatment. For AFib, either warfarin or apixaban are reasonable answers. But the board answer is warfarin for any of them.
You have a patient who's chronically on rivaroxaban and now is having very heavy menses and is becoming anemic. How would you approach treating that patient?
Oh, this is a very, very difficult question to answer. How do you treat somebody who needs their anticoagulant? Maybe they had an oral contraceptive or pregnancy-induced thrombosis and they have post-thrombotic syndrome and need to be on rivaroxaban but have heavy menses. There's no great answer. Generally, we try for local measures such as hormonal intrauterine devices, IUDs, rather than systemic measures. There are some systemic measures that are used, and for some of these are drugs such as Amicar, epsilon aminocaproic acid, or tranexamic acid. They're antifibrinolytic drugs that are taken orally by the patient around the time of their menses. The problem is they all come with slight increased prothrombotic risk, and you have to be very careful about using an anticoagulant and a prothrombotic together in patients at the same time. Okay, there's no great answer to this question. You're basically, but local topical measures such as IUDs are much preferred rather than using systemic type treatments for patients with menorrhagia while on anticoagulation.
You mentioned that very obese patients, there's difficulty in knowing the right doses to use with some of these agents. Is there a way that you can use anti-10A levels and dose adjust some of the DOACs in those patients?
Yes, there is. So the question is, you have somebody who's very obese, over 120 kilograms, but they absolutely will not take warfarin or weight-based low molecular weight heparin, and they insist on being on a DOAC. Can you possibly manage them? With a little bit of a challenge, yes, you can. So you can do 10A levels. You just have to do them accurately. So most of them you have to draw it 4 hours after the last dose. So timing has to be accurate. And then you get the level back. It takes about 4 or 5 days for it to be shipped to a central lab and for you to get the result back. But remember, this is not warfarin. This is not low molecular weight heparin where you have graduations of 60, 80, 100 milligrams of Lovenox. You don't have that for rivaroxaban and apixaban, right? You have very limited ability to change the dose. Apixaban comes as 2.5, 5s, and 10s. And I think your ability to titrate is much more limited purely because of availability of tablet size. So it can potentially be done, but it's a lot more challenging than it is for something like low molecular weight heparin, where you have several denominations of drug dose.
What is your recommendation for VTE prophylaxis following orthopedic surgery? Is aspirin good enough?
If you ask an orthopedician, the answer is yes. I showed you some data for risk reduction with aspirin, right? A 20% risk reduction in unprovoked VTE patients compared to placebo. So it's a good drug, it can help. But it's not something that I can easily wade into because the orthopedic literature is somewhat different from the hematologic literature. If you ask a hematologist will tell you that the bleeding, the antithrombotic efficacy of an 81 milligram aspirin is as good as a 325 milligram aspirin, and it lasts for several days, okay? But an orthopedician will use twice a day full dose aspirin for anticoagulation. Why? Because that's how their trials were designed. They don't like anticoagulants, either DOACs or Lovenox or Coumadin, anywhere near as much as they like aspirin. But there is solid orthopedic literature to support using aspirin in select lower risk patients who undergo hip or knee replacements. It's really different for hip versus knee and based on their risk assessment profile. But the orthopedicians and hematologists have slightly different approaches to this. But there's several ways that this could be done.
Back to some questions about cancer screening. If you have a young woman who has a unprovoked VTE, is there any benefit of considering screening for ovarian cancer?
If you look at the overwhelming body of literature in younger patients, the answer is no. You're very unlikely to find cancer in somebody who doesn't necessarily have a high risk. So if there's a family history of ovarian cancer, perhaps you could get imaging when they present with their PE, also looking at the abdomen. But on a population level, there's very, very low chance of finding occult malignancy in somebody who's young, who's a non-smoker.
Patient comes into the hospital with a pulmonary embolism. This is not a group of medicines that you recommended or talked about, but just a question, when would you consider thrombolytic therapy for that patient and not just a DOAC?
Yeah, so great question. When do you use thrombolysis? And there's two types of thrombolysis, right? There's thrombolysis for a life-threatening PE, when there's cardiac compromise, when the echocardiogram shows that the septum is bending, and when it's truly a life-threatening PE, that's when you can use systemic thrombolysis. But there's also thrombolysis for proximal DVT causing major symptoms. So somebody who's clotted off their entire iliac vein all the way down to their popliteal, and you have this phlegmasia kind of picture, the leg is swollen, there may become compartment syndrome, may result soon. That's another case where catheter-directed thrombolysis may be necessary to save the leg. So those are two situations in which we consider thrombolysis truly life-threatening PE and limb-threatening lower extremity DVT.
In patients who have had a history of a DVT in the past and now need to go on some prolonged travel, do you recommend any type of medication prophylaxis for them?
So great question. Somebody who has a history of VTE, and it would depend if they have provoked versus unprovoked, but for unprovoked patients generally should be on some form of prophylaxis. So we'll take the case of patients with provoked VTE in the past who are going to travel. There are two strategies you can use. One strategy is to use aspirin, 20% risk reduction, as I showed you before. The other strategy, which I'm actually doing a lot more of, is use one of the DOACs. Use either apixaban or rivaroxaban. Remember, this is prophylaxis for a recurrent clot. You don't have to use treatment doses. You can just do a single dose before they get on the flight. Okay, this is not like extended treatment. So that's a strategy that I very frequently use in patients who are not on chronic anticoagulation, who had a prior history of a provoked clot, and want to do something before they get on a flight to Paris or something like that.
And finally, you talked about how you don't like long-standing IVC filters. Unfortunately, we have many patients who do have long-standing IVC filters. Do you try to remove them, or do you just anticoagulate them?
Yeah, it depends on how good your interventional radiologist is. Okay, that's the short answer. But they have taken out filters that are even 10 years old, and they'll take it out. The interventional radiologists will take out the IVC filters if they're causing problems. If they're chronically thrombosed and patients having major symptomatology, they actually go in with lasers and cut the filter out. See, the problem with the filter is it's kind of like an umbrella, and it's got spokes on the side. It gets stuck into the sides of the IVC, and extracting it can be really hard. And once you get beyond that 6-month mark or so, extracting it gets harder and harder. So they use lasers to cut out the kind of the arms of the IVC filter and then pull it out. When they've done it they actually have like a record of, longest IVC filter before it was removed. And I think the record now is 1,500 or 2,000 days, but it's constantly being challenged. So it depends on how good your interventional radiologist. It can be taken out if it's causing problems, but if you can't take it out and there's chronic problems related to the filter, these filter clots can be absolutely horrific. Then that itself may be a reason to keep a patient on anticoagulation to prevent thrombosis.